Welcome, everyone. My name is Robert Hamilton, co-founder and chief scientific officer of NovaSignal. It is my pleasure to introduce Dr. Ira Chang, who will be presenting her work on the new successful stroke workflow using robotic TCD to screen for right to left shunt in the evaluation of cryptogenic stroke. Dr. Chang is a board-certified fellowship-trained neurologist as part of the Swedish Neuro Network. She received her undergraduate degree from Yale and then moved to Colorado following her medical training. In 2005, she founded Blue Sky Neurology with her partner and has transitioned into the newly emerging field of neurohospitalists and neurocritical care. She is the medical director of acute neurological services and chairman of the neurology section at Swedish Medical Center. Dr. Chang also teaches neurology residents as an assistant clinical professor at the University of Colorado Health Sciences. I'll be moderating today's webinar, and if you have any questions, please leave them in the chat. But with that, I'll turn it over to Dr. Chang.
Thank you so much for that introduction. I have to thank everyone in advance for listening in on our review of our data with using NovaSignal to detect right to left shunt. So with that, I'm going to start off and go through really some of the background that led to us wanting to incorporate this new system of transcranial Doppler in, as well as, I certainly can answer questions at the very end regarding more detail specific about implementation. And then we'll look at reviewing the data on the first 200 patients that we have. I believe we're probably into about 250 patients when we first started and launched this in the beginning of January of 2022. So we've been able to collect data very quickly. So really the background is that in the cryptogenic stroke population, and really we also were looking at, stroke in young age, as we defined age less than 65, we have been looking at evaluating for cardiac causes of stroke, particularly patent foramen ovale. And certainly we can go into this talk isn't really to go into the pluses and minuses of, treatment of PFO or the actual treatment or closure or anything like that, but just really, I think recognition is the first step. So, currently the gold standard has been transesophageal echocardiogram, and as a screening transthoracic echocardiogram with bubble. And there have been a lot of studies over the years that have shown that transcranial Doppler actually has a much higher and better sensitivity towards detecting right to left shunts. Just as a kind of background here, we already talked about the scope of patients who have cryptogenic stroke. I know we've talked about historicals have shown about 20% of the patient population have patent foramen ovale, but the challenge really is to figure out which one of those are symptomatic and do we really care? I know we had a lot of discussion about whether detecting more PFOs actually leads to more unnecessary closures, but I think some of the information that we'll show and future work, I think, is going to be to try and answer that question to help us identify which PFOs do we think are more significant. So, as I mentioned before, we have the main standard evaluation for PFO is, or any kind of right to left shunting, is with transthoracic echo. That's what we used to do first line, certainly readily, I put here readily available, but I think one of the things that drove us to look at this in 2021 is that with COVID and with just short staffing in general, we were actually very behind and short staff on echocardiogram techs. And it was sometimes taking 2 or 3 days to get an echo with bubble study on our patients. So we looked at this also as a way to cut down on that echo staffing time. Certainly transesophageal echocardiogram, it has been the gold standard, and it is much more sensitive. but requires a cardiology, consultation, as well as a cardiologist to do the test, and we were not able to really do that on weekends. In addition, the reason that the sensitivity, as you can, is less on TEE than transcranial Doppler is that if you look at the anatomy of PFOs, it's really kind of a membrane that opens up with Valsalva and strain. And so when you've got this ultrasound probe down your throat, you might not be able to generate as good or strong of a Valsalva as you can when you have a transcranial Doppler over the middle cerebral arteries. So with that information, we wanted to look at this system of NovaSignal, which is more of an automated robotic TCT technology. For those who've been at our center at Swedish, probably back in the 2015 timeframe or so, we actually did institute transcranial Doppler as part of the stroke workup in cryptogenic and young strokes, but it was kind of a manual head holder for detecting the signal. And we did have to, as a neurologist, come to the bedside and do the bubble injection and read it at the bedside. And that just got to be too difficult to do with our schedule. So we actually ended up not utilizing that. So when this came up with the automated robotic TCD technology, we're really able to have, because of the head holder that is very easy to put on based on kind of guidelines, and placement, as well as these little fiducials that guide where to place the ultrasound probe. Then the AI technology is used to actually hone in on the signal. And once it finds the best MCA signal, sometimes it'll pick up a PCA or ACA, it will lock in on that. And even if the patient moves a little bit, it'll kind of lock back in on that signal. So with that, we were able to train our ultrasound technicians, and really any other alternative staff to do these studies. Additionally, we have this Nova Guide View, which is pictured here, where the actual results can be viewed on your iPhone or whatever smartphone, along with the ultrasound audio, which I think is very important in terms of hearing the little bubbles and the emboli. So looking at the system, we felt that this might be a much easier way to incorporate TCD into our stroke workflow. There was a study recently that last year presented at the International Stroke Center. That was a multi-center trial by Dr. Mark Rubin at University of Tennessee. And they wanted to look specifically at using this technology, TCD technology, versus echocardiogram with bubble study in the same patient. And they found that their rate of right to left shunt detection was 63% compared to 20% in echo with bubble. So, and they actually were able to also find also higher number of large shunts, which is really, I think, the population and the population that we are really want to be concerned about is causing a stroke. And that number was, as you can see, 27.8% versus 10%. So here is our workflow. So when we, and our algorithm for admission, when we introduced TCD with bubble, and, all of our patients who have TIAs and strokes do get admitted at least overnight for a stroke workup. And so we started with the inpatient population because as opposed to any outpatient populations, as we thought this was a very kind of set population. We neurologists see every single stroke and TIA patient, and we put in all the stroke orders. So we were able to set the algorithm as being, this is what we generally do on an admission stroke order set. We usually get, vessel imaging, MRI, and we were getting echo with bubble, but in place of that, we substituted TCD with bubble for patients who are aged less than 65 or might have other risk factors such as a DVT and malignancy or something, even if they're 70, who had a stroke. Of course, telemetry in the stroke labs. We were able to train the ultrasound technicians to perform the TCD study. And if they did not have a bone window, which you'll see later what our bone window rate, no bone window rate was, then they would go ahead and get an echo with bubble. Once the TCD was performed, then we had trained our neurologists to read these TCD with bubble studies and got them credentialed to our hospitals. So instead of the radiologists reading these, we had our neurologists who are also the ones seeing the patient, and it's very objective, as you'll see later with some of the examples. So the study was uploaded to NovaGuide View, which we can look, and look on our phone, and then we would generate a report, put it into the EMR. Patients generally who had a right to left shunt that was low grade, Spencer 1 to 2, or thought not to have, were generally evaluated further by our neurologist to be able to determine, do we think the PFO is a cause of the stroke? If not, what is the cause? And if it is the cause, then, we should refer them for further workup, maybe a TEE or cardiology workup. Patients who had a higher grade shunt from grade 3 to 5, we did usually get a cardiology consultation for further evaluation and workup. And much of that was done on an outpatient basis. Again, this was also a period of time when we were very short on hospital beds, and we're looking for ways to be able to move these patients from an inpatient workup to an outpatient workup, which the cardiologists were able to see these patients in their offices for the rest. Most of these patients usually ended up needing some type of Holter, 30-day Holter monitor, or loop recorder, or something for a period of time before further testing for whether a PFO should be closed and getting neurology input in on that. So that's a whole nother phase that we'll hopefully be able to report on in the next few months. So the purpose of this study is to review. I started off with 100, but I have now 200 patients to review. We kept data on each one of these patients retrospectively to determine, one, just to look at how feasible was this process in these 200 patients, and then to look at what was the rate of right to left shunt detection and the distribution of the shunts from low grade shunts to high grade shunts, and then also look at what was our medical management and what was the disposition on discharge of the patients. I have to thank my residents, Dr. Izaguari, Dr. Wicknick, and Dr. Brejna, who helped with the data sort of abstraction from the medical record and the chart. So here's the shunt detection rate. And I'm really, just to highlight, this is right to left shunt because I'll show you later that not all right to left shunts are PFOs, but just what we're detecting as emboli getting into the brain. We found with our total 200 scans that were the first 200, and we collected data on all of them, except maybe there was only 1 or 2 that we couldn't collect data on since they discharged AMA or before their workup was complete. But so we had essentially a 56% positive rate of detecting a right to left shunt of all grades. Of the high grade shunts, 3 to 5, we had 47 patients, or a rate of about 23%. 3.5%. And then we had 7 patients, and actually that might be 9. I apologize, I have to correct that, but did not have a bone window, which is still very low. I believe the generally published rate of no bone window is about 15% or so. In the first 100 patients, we had some patients who also had an echocardiogram with bubble, even if they did not have a bone window. And I'm not sure if the reason for that, I'm sure before the process, everyone got used to the process. The hospitalists would order echoes with bubble while we were ordering the TCD with bubble. And so some of the patients did get both. But as you can see, even amongst the patients in the second column, patients who had a positive right to left shunt on TCD, we still on the echo with bubble had 7 of them were negative on the echo with bubble. And even those who went on to get TEEs also had negative bubble studies. So we did not have any patients who had echo with bubble or TEE with bubble that were negative that had a that were positive that had a negative TCD. They all had positive TCDs, but the flip side is that we had patients who had positive TCD with bubble for right to left shunt that went on to have negative transthoracic echoes and transesophageal echoes with bubble studies. So again, confirming that, higher sensitivity. We were, there were a couple that were identified that were either, I think one, pretty severe, like, clot kind of hanging in the heart, just ready to cross the PFO, that did end up getting closed. And there was one case that I'll show you later that was not a intracardiac shunt. Okay. This is just to familiarize everyone with what the Spencer grading scale is. And this is what we use to grade a right to left shunt. So the signal that you see that we will get from the TCD system is right and left middle cerebral arteries. And we're looking at the signal in these arteries. Once they're locked in, then we'll look at just looking at rest, usually for a short time period. Then we'll give a bubble injection at rest with no Valsalva and see if there are any bubbles that show. And then there's also another injection that occurs when the patient has a Valsalva strain. And we'll see if that leads to any additional bubbles, which theoretically it could. But the grading system here, you can see on the upper left is a grade 0, so there's no bubbles. And the MES means microembolic signals, which essentially are the bubbles. The grade 1, you might see it's 0 to 10 bubbles. So you can see one little one there. If incidentally, sometimes we'll have patients, we can see a signal on one side, but not on the other side. And how we handle that is we double the number of bubble counts on the one side, because theoretically they should go pretty evenly distributed evenly bilaterally. A grade 2 right to left shunt is from 11 to 30 bubbles. So down at the bottom, sort of an example is you'll see, a few bubbles over, and this is over a minute time frame. This is just one screenshot of a minute, and it'll just run through. So that's a grade 2. So generally, we think, in general, even with the strain, if you have a grade 2, that, it's a pretty small shunt. For a grade 3, which is what we would consider to be a large shunt, you can see that the bubble count is 31 to 100 for a grade 3. And so each of those little bright spots are emboli. And grade 4, it should, a little bit more filled in. And then grade 5 really is what we consider to be a curtain sign. You can't really, it's hard to really count the number of bubbles in that, but we actually do, the program counts the number of bubbles, but we, as the reading neurologist, will also try and count them and confirm the numbers. So that's what is meant by Spencer grade. Let me try to show you if I can here, just on here an example. I think just so you can see the quality of the video and the audio. So I'm going to try to see if I can play a patient's. Not sure why that's, let's see. I just looked at that this morning. One second. If I can't get this, we'll move on. You know, it's always, that's why I never include videos into the presentations, because sometimes inevitably when you want to show it, it never turns out. Okay, here we go. So if you can hear all that, see that. See those bubbles, and can you hear those? Oh, sorry, got a little fuzzy there. Let me back that up so I can, it got kind of fuzzy on that. So this is after bubble injection. So each of those little sounds. Okay, well, you guys all get the idea. So that was a grade 4 shunt with Valsalva. All right, so yeah. So what we found on the patients in terms of, here's just a distribution of, you know, the number of what we found. We, you know, so we had 75 patients who actually had no shunts identified. There were some that could not perform the Valsalva strain, even with the TCD. I mean, there, you know, these patients are, some of the TCDs were done in the neuro ICU. Some of these patients were aphasic, so they didn't quite understand how to do a Valsalva strain. But if even on an intubated patient, you can stimulate, you can inject the bubbles and stimulate a Valsalva by doing a suction. And so when they're coughing, that can also simulate one. There's actually something called a calibrated Valsalva, where they blow into a certain tube to make sure they have a really good effort. And there's, again, other ways to try to help these patients. But, you know, sometimes they just weren't able to follow the instruction. And I think, you know, they can have their TCD with bubble study done at a different time. So those are the ones that I could only get data on the REST study, but not with a good Valsalva. We had 60 that had either at REST or Valsalva only. They had a 0 to 2 grade. And then we had some that were really very minimal shunt at rest, but with the Valsalva, they really had an increased number of bubbles. And that was the example that I just played for you. And then there were some that even at rest, they had a fair amount of bubbles at rest, and then certainly with strain as well. So here's kind of a breakdown of what we found in terms of the breakdown of how did the neurologists, and this is all of our inpatient neurologists, treat these patients. And I looked at, in reviewing their last neurology progress note, as to whether they thought the cause of the stroke was the PFO, and whether it was, you know, grade 1, 2, 3, 4, no bone window. And if they did not think the PFO was the cause, even if they're, you know, a positive PFO study, right to left shunt study, what was the cause? So looking at here, of the grade 1 to 2 shunts, I mean, by far, most thought that PFO was not the etiology. So you can see 51 of 11 patients. The 51 patients that were not thought to be PFOs thought to be cause of the stroke, you know, a lot of them were AFib, cardiomyopathy, dissection, intracranial stenosis, small vessel disease, a fair number that were cryptogenic, meaning I think at the end of the evaluation, if really there was nothing found and it still looked like not a small vessel or other disease, I called that the cryptogenic because we just don't know. So essentially needs further follow-up. And then there were some that were stroke mimics, migraines, or iatrogenic, or various other causes. Of the 11 on the upper left that was thought to be PFO as a cause, and I included possible cause as well as definite cause, because we don't necessarily always know right at the time of discharge, but maybe referred on for further cardiology evaluation. The patients were placed on aspirin, dual antiplatelet therapy, sometimes anticoagulation because there may have been a DVT or a hypercoagulable state. And I think those are the cases where maybe a small shunt was thought to still potentially be a cause of the stroke, is that if there's an associated hypercoagulable state. And then we had one patient who signed out AMA. Of the patients who were found to have a grade 3 to 4 shunt, certainly I think, and it seems to make sense, but I don't necessarily, and I do think some of these, so one might answer, question, did we make this determination because we found the PFO, or was it could they think in terms of lack of other causes? I mean, I'm sure it's taking all this data together and at the end of the admission saying, okay, I do think this is significant. So 37 of those grade 3 to 4 shunts were thought to either be likely the cause of the stroke or possibly the cause of a stroke. And those patients were generally discharged on really a variety of aspirin, dual antiplatelet therapy, and anticoagulation. There were a couple that, as I mentioned before, were closed while they were still in the hospital. And of the grade 3 to 4 patients that were not thought to be the right to left shunt has caused the stroke, there were 9 of those, and the causes were generally, pretty obvious: intracranial stenosis or small vessel disease, AFib, probably also, conversion disorder or migraine is what I noticed. Of the patients who had no bone windows, they went on to get an echo with bubble. You'll see that 8 of them, just based, I think, on the echo result, were thought to possibly have PFO as a cause. So they were placed on a variety of treatments, as you can see, and 6 were not thought to be right to left shunt induced. I also wanted to include data in on those 75 patients that did not have a PFO found, and in general, what were the causes of stroke. We had actually a fair number of patients who still, after all the workup, as you can imagine from what we presented earlier, that they're still left as cryptogenic, embolic looking strokes with all the workup being negative in terms of determining the specific cause. Okay. I wanted to actually show you one, this was a case report that I presented at the Neurocritical Care Society out of one of the patients that came from our patients that I thought was really, was very interesting, because it's not something I had really thought about as a cause of stroke. As I'd mentioned, we found a patient who had a large right to left shunt that was not caused by an intracardiac shunt. So this is a 38-year-old man who came in with visual symptoms. He was out of the time window for TPA. He had fairly mild symptoms. Here, I think his NIH stroke scale was pretty low. Actually, it says no thrombolytics given to low NIH and non-disabling, and he did not have a large vessel occlusion on the CT angiogram. So he's placed on dual antiplatelet therapy. Age was 38. So we went on with the stroke and young workup, and you can see down on the bottom left that there is a medial occipital infarct on the brain MRI scan on the bottom left. There was a small branch occlusion in the right PCA that was seen on CT angiogram. The patient went on to get the TCD with bubble, and immediately at rest after the bubble injection, he had a grade 5 curtain sign, right to left shunt. And then on the Valsalva, he also had a grade 5 curtain sign, right to left shunt. So the patient had just an echocardiogram without a bubble study, as is our norm, and had otherwise a normal EF of 65%, no other valvular disease, and maybe an eustachian tube present. The patient cardiology was consulted, got a TEE with bubble, and noted that that was positive, but kind of graded as a moderate amount of bubble between the second and third beat. We went on to get ultrasounds, as is our practice if someone has a PFO and a stroke, and there were negative for DVTs. Because of the severity of the shunting, I believe after talking to the patient, and they were actually, didn't have much in the way of deficits, they wanted to pursue PFO closure while they were still in the hospital. So the patient was taken for catheterization, and there was no PFO that was found. There was no connection that could be seen between the right and left atria to close. So the patient then went on to have a cardiac MRI to see better the intraseptal anatomy. And on that cardiac MRI, they found a pulmonary AVM. So I don't know if you can see on the CT angiogram there that there is a connection where I put the arrow. There's a clot inside where the bright spot is artery, and next to it there's vein. So there and on the and so that's a direct connection between the pulmonary vein and the pulmonary arteries, so that that is another source of thrombi that can get into the into the arterial circulation and cause a paradoxical embolism. You can see down here on the pulmonary angiogram, there's a kind of a bleb there of a pretty significant size pulmonary AVM, which was coiled. So it was an embolization coil that was done by one of our interventional radiologists. So, I thought I highlight this really because I think if this patient had never gotten the TCD with bubble showing the grade 5, I think we would have gotten the TEE, showed a moderate PFO, put him on, maybe we put him on anticoagulation, maybe put him on dual antiplatelet therapy, maybe put him on aspirin, as you can see from our behavior, how we manage patients, even with the larger shunts, and then they would have gone home. And who knows if they would have had another stroke, because nobody would have really done a CT angiogram of the chest is really not part of our workup. Another thing about, pulmonary AVMs, which I know most of them are very small and probably not of any clinical significance, but right to left shunting in and of itself can have consequences. Most patients will compensate for a little bit of hypoxia that they can get from right to left, from a persistent right to left shunt by, increasing their red blood cells. And it really only comes into play when they're really stressed, but under normal exercising conditions, they are doing fine. I have someone I know who ended up becoming very symptomatic while they got COVID. So they had pneumonia, got hypoxic for other reasons, and really decompensated because they had a persistent right to left shunt. So I think that is something to think about, when we see a right to left shunt. It's like not everything is, has to do with causing stroke. The other thing about pulmonary AVMs is that they are actually a significant source of endocarditis or bacterial emboli, because they can get infected, and not ischemic strokes, but there's also some question of whether they might have something to do with migraine. So I think that's a, kind of something that we can start thinking about when we have a large right to left shunt. I think we have to think about pulmonary consequences of the shunt other than just, whether it causes a stroke or not. Okay, so in conclusion, so few observations and conclusions. I do think that certainly the feasibility of incorporating robotic automated TCD into our stroke workflow and algorithm, I think we were able to demonstrate that. It's I think very easy to order. It's part of our stroke workflow. We're able to train people to do the tests. We, really chose our ultrasound techs, but really could be any other, personnel that you have in the hospital that has the time. We were able to train our neurologists to read the results. So I think that's, something that the neurologists were really interested in, as well as, having another procedure to do. And we were able to discontinue bubble studies on echo testing, which really the second 100 patients I looked at, I think almost not a single one of them had an echo with bubble, to avoid unnecessary duplication. And so if that's an issue in your facility or hospital for echo techs, then, this may be a solution for that. And certainly being able to not wait for the cardiac workup in order to discharge a patient, I think was an advantage. And certainly I showed you on the Nova Guide view how easy it is to hear and see the results really for anyone, not even just the reading neurologist, but if cardiologists want, residents and other people want to be able to view the results, I think, as long as they have access, they can. Other observations from a clinical point of view was that certainly the sensitivity was, as we would expect, much better than echo or TEE with bubble. We were able to find other structural causes that could cause stroke other than a PFO that might have otherwise been missed. Grading of the right to left shunt, I think, is more straightforward and objective and consistent than what you can get on the echo and the TEE reports in terms of quantification. Certainly the TEEs are done as well, just because of looking at other anatomic factors. And I think in general, our neurologists thought that the higher grade right to left shunt, those patients who had the higher right to left shunt, I think our neurologists did think that it was possibly more likely to be or possibly the cause of the stroke, though I think the treatment still kind of varied, and they were referred for outpatient workup. And occasionally, if there was a right to left shunt that was thought to be particularly at high risk for recurrence, we did close one or two of them in the hospital, or at least hopefully put them on anticoagulation while they were getting further workup. I think some of the things that this information really does kind of gives us for next steps is we want to follow up on all these patients who are referred for outpatient cardiology evaluation and neurology follow-up to see what the outcome was, and certainly make sure also that they were followed up. And then even if, I think this also would be helpful to see, to do a longitudinal follow-up of the high grade right to left shunts, for whatever medical management or closure they have, but if they're on medical management, just to see, for the next few years, are there any follow-up neurologic events, or, that's more of a prospective study, but I think that's really important, because this goes into whether, of the 20% of the population who have PFOs, which of those 20% can we identify the ones who have higher risk for stroke, and should we treat them then appropriately? I'd like to go back and review our current data and calculate the ROPE scores on all these patients, along with the cardiology follow-up. I know there's a patient, there's this paper recently published that looked at Pasquale scores and TEE and PFO closure to make a clinical correlation there, but I'd like to use this data and use the ROPE scores for that as well. Trying to, again, correlate and look at medical management, if we find low-grade shunts versus high-grade shunts, should we be putting patients with higher grade shunts more on anticoagulation or dual anticoagulation while they're getting worked up? You know, I don't know the answer to that, but we can look at that. And then I think for high-grade shunts, we also want to consider whether they should be referred to a pulmonary specialist or maybe have pulmonary function testing or something to see if they have other causes of pulmonary or cardiopulmonary dysfunction other than just the stroke itself. So I think that concludes my talk. So if anybody has questions, I'd like to entertain them now.
Yeah, no, thank you, Dr. Chang. And there's a number of questions. The first, I'll start kind of on the clinical side. Could you clarify your workup for the small grade shunts, the Spencer grade 1 and 2 shunts?
So for the small shunts, it was really up to the neurologist whether they wanted to pursue further cardiology evaluation or not. I think in general, most of those patients were thought to be that the low grade shunt was thought to be not significant and no further follow-up, I think was done. There were a few that I think 9 of those that were thought to be possibly as PFO cause, and those would have been referred for further like TEE or cardiology evaluation, like a loop recorder or something like that too.
So a couple of questions on the actual kind of call it TCD protocol piece of it. Coming in 2 questions. Do you have anyone that can do basilar artery insufflation with the TCD bubble studies?
So that would be, we do have the ultrasound techs who can do a manual transcranial Doppler. So it wouldn't be with this robotic system, but we could certainly do that if we wanted to.
So I think the next question on that is a comment about the no window rates. It has been shown that even if you collect, or even if there is no window, you can have the probes insonate where the MCA might be and then inject anyway, inject anyhow. If the patient has a shunt, you'll magically find a window. The downside is if negative, you don't know if you necessarily missed that or whether or not it's a true negative. So I'll form it into a question. Were you, if the subject had a no window, were you still injecting bubbles?
I believe, yes, we were on some, and I wouldn't say, I mean, if there was, some were just completely like really nothing to be seen, but if there's, a hint of, sometimes we are able to get a little bit of an ACA or PCA or, some very weak signal that would not be good enough to get any measurements off of, for the MCA itself or velocities. But we did find that when you injected with bubbles and there were bubbles, you'd say, well, okay, well, that's not a artifact, because it goes with the timing. So we were able to use that. And maybe it might have underscored the number of bubbles, but if we did see bubbles, at least we had an indication of a shunt.
Next question was really on the performance. Did Echo, either the TTE or TEE, pick up the shunts that the robotic TCD missed?
No, there were none there were no shunts on Echo or TEE that were TCD negative. So meaning is that there were Echoes and TEs that read no shunt when the TCD was positive, but there were, of the TCDs that were negative, there were none that had a positive Echo or TEE. And one thing about the even with the strain part on an Echo with bubble is that when you have a probe, and if you're really doing a strain and bearing down and coming, and if they move their chest, sometimes the probe slips a little bit, even just a tiny angle. So it's a little easier to miss, bubbles, I think, going across the shunt. And the same thing with the TE, but we did not have any that were positive that the TCD missed, unless it's no bone window.
Yeah, as a follow-up question, were there any TCD positive cases, TEE negative cases? Were those small shunts or were those larger shunts?
So on so this goes back to here. So TEE with bubble. So you could see the top line, 5 negative TCD, of which they had 5 negative TEE, no positives. Let's see, so positive right to left grade. No, let me look at the grade 3.
So
grade
it looks
3.
like one of them.
Yeah, one of them was negative. 6 were positive. Now, our TEE reports, that's the one thing, is our reports really just sometimes they don't specify. It's like small, moderate. I don't recall that it was large, at least, but they're just not as specific about the degree of shunting. It's like they usually say moderate.
Thanks. A follow-up question: do you define no window R8? Do you have the no windows and the robotic TCD positive cases in the cohort? So if they were, I'm assuming, a no window that you were then found that you did an injection, you found a positive window, those would be moved from the no window into the positive section? Is that how it would be interpreted? Those would no longer be no window?
Yeah, yes, correct. Yeah,
Okay.
if we were able to, I mean, no windows are truly nothing. No signal.
I had one follow-up question on the TCD protocol. Were you doing these patients supine? How was the protocol done? I know you mentioned the rest in the Valsalva earlier, but from a kind of head of bed position level.
Yeah, so I think they're usually like 30 degrees, 40 degrees up. They're not really fully up, because the way the probe system works, the patient is laying their head on a head holder, and they have the TCDs around the side, so they are usually leaning their head back on the bed. So usually it was supine, but with some degree of elevation. I mean, they can go up to, I believe it's 45 degrees. You might know better, but I think they can go up quite a bit if needed.
Yeah. Looks like we had another follow-up question. If you're granted to perform one prospective trial with the NovaGuide in RLS patients, what research question or hypothesis would you ask? What is the last remaining question for you out there?
So I really would like to do a prospective study to follow patients with grade 3s and grade 1-2 shunts, just natural history, and then look at the medical management. And I just would really like to see if there is a higher incidence of recurrent neurologic events, stroke, or TIAs in the higher right to left shunt group that was treated with medical management versus the lower grade shunts, because again, that goes into the situation of, no, just because we find a PFO, what does that mean clinically? And I would again just think from a kind of general point of view, like I would think, oh, okay, well, I would think a larger shunt would lead to more risk for stroke, but there are a lot, there are a lot of people who maybe don't believe that, or we don't know. And then along goes with that is the medical management piece of it, which, that's a whole bigger study, is not to get into PFO closure and all, but I think I'd like to go back and relook at, the general 20% of the population has PFOs, so why do we care question.
Great. Well, I think we're getting close to time, and there's no more questions. Dr. Chang, thank you very much for your presentation today and all the hard work on this project.
All right. Thank you very much. All right, everyone. Have a good day.
Thank you, everyone.